Welcome to today's webinar hosted by VitaFlow, titled The Role of the Dietitian in Improving Patient Outcomes in Pediatric CKD Mineral Bone Disease. A few housekeeping items before we get started. The webinar will last approximately 60 minutes and will include time for your questions at the end. If you would like to ask a question, please use the question feature on your GoToWebinar toolbar. All questions will be screened and a select number will be answered by the speaker at the end of the presentation. The webinar is being recorded and will be available on VIA in the next 2 to 3 weeks. You can access PDFs of the presentation slides, a certificate of attendance and a self-reflection tool in the handout section of the toolbar. Please take the time to download these now. The views herein are of the presenter and do not necessarily represent VitaFlow's views. The material herein is accurate as of the date presented and for educational purposes only, and is not intended as a substitute for medical advice. VitaFlow is delighted to introduce our speaker for today's presentation, Leila Kizilbash. Leila is a pediatric dietitian who has been practicing for 20 years. Leila joined the paediatric team at the Great North Children's Hospital, Newcastle in the UK in 2001. Leila started working in paediatric nephrology in 2006 at the same hospital. Leila's caseload includes a wide variety of renal patients, including those on dialysis, as well as transplant patients. Leila has completed her postgraduate diploma in practice education in 2004 and has co-authored on a qualitative study of how the MDT supports parents of children with CKD, and is also the author of both the AKI and CKD sections within the renal chapter of Pediatric Dietetics, which is published this year. Leila is a previous secretary and also chair of the PRING group of Pediatric Renal Dietitians in the UK. Leila has presented at conferences on protocol development in CKD, MBD, blended diets, and nutritional management of AKI. Leila is also a member of the Pediatric Renal Nutrition Task Force, an international group of pediatric renal dietitians and pediatric nephrologists who are creating clinical practice recommendations for worldwide use. VitaFlow would like to thank Leila for taking the time to present for us today, and without further delay, I'd like to hand over to you, Leila. Please bear with me a moment as I pass the controls over.
Thank you very much for that introduction, Catherine, and thank you, VitaFlow, for inviting me to speak. I think it's my 4th webinar for you. It's a wider audience today than normal, so hopefully you'll all find something useful from this presentation. It's always difficult to know how to pitch things, so let's see how I did. I look forward to any questions and feedback from this presentation. First of all, then, an overview of today's talk. I'll do a brief review of CKD MBD. I'll look at my first guideline development and what took me to it. Then we'll look at the review of current publications that then focus my direction on the second guideline. Then the easy task of addressing modifiable factors, so calcium, phosphate, vitamin D. Then we'll have a little look at what resources that you could use out there that will be helpful to your practice. So on to CKD MBD review. So you'll be aware that it's quite a multifactorial, complex situation in CKD. Where there is a decrease in GFR, there is a fall in the production of dehydroxyvitamin D3, and this can result in an increase in PTH levels, which will in turn affect your serum calcium levels by lowering them. Reduced absorption from the gut doesn't help with this, and then there's further stimulating of PTH production. And also, as a result of your reducing GFR, there's phosphate retention, which also causes hypocalcemia and rising PTH. This secondary hyperparathyroidism causes bone resorption and further increase in serum phosphate levels. In addition to the MBD, this process can lead to calcification in other tissues, so blood vessels, muscle tissues, as well as phosphate acting as a uric toxin. So all this can impact on bone health. So mineral degradation seen in CKD affects bone strength, mineralization and architecture. And then it can cause problems in childhood with bone accrual, resulting in bone pain, deformities, growth retardation and fractures. So together with the vascular classification, we need to think about these things after our future for our patients. So both the actively show to affect educational attainment, relationship status, and we have increased risk of cardiovascular disease in CKD. So our life expectancy is less in our population. So looking at these things earlier on, hopefully it will reduce these risks going forward for our population. So kind of why worry? So if you do have significant higher PTHs for a significant amount of time, that can impair growth. However, if you try and keep PTH within normal range, even with children on dialysis, you can get normal growth. Again, what is normal range though, which I'll come to later on in the talk. And then the maintenance of normal serum calcium, phosphate, PTH and vitamin D is crucial to achieve normal bone growth. And that was said in 2012, but that's no easy task, and is it as easy as that? So I'll look at how we can do that as dietitians later on. So CKD, MBD, what can we do? So the thoughts are restricting dietary phosphate in the early stages of CKD can delay the progression of CKD in children. In fact, there's a large cohort study that looked at this and showed a 2-year delay in CKD progression with phosphate to the reference nutrient intake, so to requirement, not above requirement. So that was as early as 1990 that was the thought. So moving on to how I got started. So in 2019, I started a biochemistry audit. In part due to frustration, because we all were looking at bloods at different levels, more so with potassium at that time, in that some of us would respond at a potassium of 5.1, while others would wait till it went to 5.4, and that gave mixed messages to our patients, because we could all be seeing them at different times. Around that time, I attended a talk by Professor Rees on CKD and MBD, which kind of sparked an interest and focused my mind on looking at our practice and pulling together a guideline. I found a like-minded registrar and consultant to help me to develop this and tell this to the rest of the team. So then I used that biochemistry audit and kind of focus it on CKD, MBD. I had looked at vitamin D at that time because originally the audit was mostly to do with kind of using E's and calcium and phosphate. So that's the only part that it was a shame now in retrospect that's missing from that audit. So this is our general impressions. So the results weren't always commented in the medical notes or the letters, and they were not always rechecked in adequate time. Even if they were in range, they weren't commented on. So, you know, calcium is in normal range, therefore to continue with whichever treatment we were doing. So the next person picking up the notes, because it could be one of 5 consultants or 1 or 2 dietitians, it was difficult to know what the plans had been and what the thoughts had been at that time. We felt that it would be useful to pull a guideline together to have the advice on one sheet of paper, streamline what we're doing, also to increase the awareness and importance of CKD and MBD. And the thing is as well, in clinic, consultants have a lot to go through with patients in that small amount of time, and this might help streamline it. And also for training new dietitians, and for myself also in clinic to focus my mind as well, because sometimes you do get distracted or you go off on different roads with patients. So that was that audit there, and I thought so that was on about 23 sets of notes at the time. So back in 2013, 2014, we used the literature for the Kudoki, the European guidelines, and Condigo. That was adult, but it had some pediatrics in there. We produced 2 guidelines, one for CKD stages 2 to 4, which I'll show you, and one for CKD 5. The only difference is for CKD 5 was allowance of PTH to be 2 to 9 times above the normal reference range. And also we want to increase the frequency of blood monitoring to monthly in CKD stage 5. What we proposed to change as well in our practice was at least an annual checkup of vitamin D. Act on the PTH, not wait for the phosphate to rise, so try and get in there a bit earlier. We confirmed the frequency of testing that we should be aiming for, what modifiable factors, that we should be looking at, and we were going to try and have a regular bloods meeting at the end of clinic. So we do our major clinic on the Tuesday morning, Tuesday afternoon at 4 o'clock we would meet up and review all the bloods together and make plans and document those plans clearly. That was our plan. So there is the guideline that we did, and this one was for stages 2 to 4. So you'll see we've got our PTH, ionized calcium, phosphate, vitamin D, and bicarb at the time was something that we had to keep a reference range to. And the frequency of bloods at the top there, and that was our plan. We were going to add this to our paper notes at the time, and on the back there was a grid to say what we did and why we did it. So if the PTH was up, I was tasked to look at calcium intake in the diet and phosphate intake in the diet, and then the result of that and what we were going to do. It did work well in our MDT clinic, so we had a hemodialysis clinic which met every month, and we would sit down and go through this. It worked well because we all sat in the room together, and in fact our pro forms at that clinic changed to incorporate this, so we didn't need 2 forms then. So it did really well in that clinic setting. So the CKD guidelines were out there, and how are we doing with it? Well, we're all a bit busy, and 5 years passes, and attending conferences and aware that there's new guidelines and publications out there. Should we update and look at how we're doing? So we decided to re-audit in 2019. And at the same time as re-audit, look at the new guidelines that we thought relevant to inform our practice, which are the 3 ones listed there. So the clinical practice recommendations, the vitamin D active analogues, and the KDIGO guideline there too. So we did the audit then to see how we were doing. So again, for some reason we did 23 patients. I think that's purely coincidental. CKD 2 to 5, and you can see what we checked there: PTH, vitamin D this time, ionized calcium phosphate, and alkaline phosphatase. There's 112 results, and you can see that we had all vitamin D in range. I think that might have been a bit lucky. We don't think the sample size was big enough. Probably in hindsight, it might have been better just to concentrate on vitamin D and PTH, and then look at the abnormal results maybe, and the perfect results, and then dive into those notes and see exactly why they were great or not great. I certainly think that our vitamin D and our PD and hemo populations are much better because we have an MDT clinic. Both of those patient groups now will be sitting together and go through the pro forma. The bloods meeting that we had at 4 o'clock on a Tuesday afternoon, not the PTH and vitamin D weren't always back, so that could be possibly an issue for us. And then the paper notes that we had at the time then go into the typing pool when not everything's documented in the notes. So it might have been checked, but it's then not documented in one place. We then looked at the time range for results. So just to remind you, that's what we said for the stages and how often we should check these bloods, these modifiable factors. And then you can see that it was useful to see when we were in range and when we were not, and how proactive we were with checking things. Especially when it came to PTH and vitamin D. ALP we did get quite a high result for, but that's done in the liver tests that we'd automatically, so it's an automatic check. So things like full blood count, bone profile, and U's and E's are automatic checks for these children, whereas PTH and vitamin D have to be added on. So that could be why we're not getting quite as high a percentage in those bloods. Then we looked at CKD stage. So we took those and split it back down. There's a bit of a worry for our CKD5 patients. But again, a small sample size, there may have been a reason that they weren't checked. But again, we couldn't find that reason out. So it's difficult when the next person picks the notes up to know what the thought process had been. So I presented these results to the team together with a new guideline. And we discussed why PTHs weren't always checked in range, checked always in the right time and weren't always in range. Why our documentation wasn't great, what was going on with the frequency of testing. So we looked at maybe regarding vitamin D, that we'd had a few patients that we had overshot and had quite high vitamin D levels, so there might have been some caution regarding supplementation. And so many different preparations as well, and there's no clear guidance at that time of how much supplement you should give. So we were going to focus on that in the guideline. We've moved to Paperlike now, so the notes are much easier to access and write into. We don't have to go find them somewhere else and then move to ward or move department. So documentation should be a lot easier. So those things we felt might help us. So then we produced this next guideline. Oh, sorry, before I show you the guidelines, I was going to discuss vitamin D and the role of vitamin D. So calcium homeostasis, PTH regulation, as we spoke about earlier on, may have a role in prevention of cardiovascular disease, anemia, infectious and autoimmune immune conditions, and offer renal protection. So our population do have a greater risk of deficiency, and it could be due to less activity, less sunlight exposure, especially if you're in the North East, especially at the moment. Reduces, there's a reduction in synthesis of vitamin D in the skin, dietary intake, reduced production from the liver and from the kidney, and then you get some losses in dialysate, the protein dialysate. So there's plenty of reasons why our patient group would have a low vitamin D. So if we just go to the three pieces of literature that we looked at to focus our guideline. The first one was the treatment of active vitamin D. It talks about the assessments and making sure you have the correct assay in your labs, which we do. So you have, we call it total vitamin D in our labs, not 125. So just double check that with your labs. Concentrations maintained above 75 nanomoles per litre, and that accounts for seasonal variation. And there was one trial there that if you had a vitamin D level above 75, it took longer to develop secondary hyperparathyroidism. Then classification of vitamin D status then was slightly different to what we've been using. So sufficiency now was above 75, whereas normally it was above 50. And insufficiency and deficiency are noted there. So that will change our focus on vitamin D as well. If you get a chance to read these clinical practice recommendations, please do, because they do great summaries at the beginning, and you can delve into more detail into each of the recommendations. So if you do get a chance, I do recommend you have a read of them. So monitoring then, 6 to 12 monthly, depending on the stage and on your blood results. So if you do supplement, there's a suggestion going back after 3 months. The difficulty we would have with that in our team is we wouldn't necessarily see someone CKD stage 2 or 3 in 3 months. So whether we bring them back for that, especially if they live far away. I mean, at the moment with COVID, we're actually doing a lot of our bloods locally. So probably that will change our practice even more than that we do get the bloods in local hospitals and chase them up instead of bring them back up to the main centre. So I suppose that will change our practice a bit. You'll see a comment about no studies that examine frequency of monitoring and outcomes. And also leaving, if you do intensive replacement, to leave them longer because there's a perceived safety of vitamin D therapy. So this is the recommendations for vitamin D supplementation based on their serum levels and their age. Now, as a team, we were quite nervous at giving 8,000 international units and leaving them for a period of time, especially if we are not going to see them after 3 months. So we have adapted this table for our practice, which you'll see later on in this presentation. But this table is a really nice way of summarising what to do. The only thing it probably doesn't bring for us was the preparations that you would then choose for these children. And also we've adapted that into our guidelines so that it's very easy to go, okay, they're over 1 year of age, their vitamin D is 50, they should need 2,000 international units. This is what you would prescribe them from our BNF or formulary in the hospital. Toxicity then just talks about what the ideal level should be and when you should look at stopping or reducing the supplementation. So the range is 75 to 125, and certainly when you get to 125, to then go to maintenance and just watch the blood. I have seen where we have complete stop vitamin D and we've got to 125, that is going to drop quite quickly in the next 3 to 6 months, depending on the patient. So if you're not seeing them for a while, then you can miss the boat again, then PTH should start climbing. The next guideline was for the vitamin D analogues. Again, a great summary talking about the reasons why you would have problems with CKD and MBD. So there's a decline in renal synthesis of active vitamin D with a decline in kidney function, and what this does in regards to FGF23. And then low serum levels contribute to hypocalcemia and a spectrum of CKD and MBD. And it suggests also to look at modifiable factors, and serum concentrations of PTH and ALP are poor markers of bone status, but they're the only ones we have at the moment to look at vitamin D therapy. Measuring FGF23 is quite costly, so that's why we use the PTH and ALP. But as that suggests there, PTH increasing, things have already been happening in the background for a while with FGF23. So again, it stresses the importance of modifiable factors, looking at things in trends, and looking to the management through diet, using calcium-based or calcium-free phosphate binders, vitamin D supplementation and dialysis prescription. And also mentions that we can get defects developed even in CKD stage 2, and this will happen before you see PTH rise. So the question is, I suppose, do you start looking at CKD stage 2 and reducing phosphate in the diet? I think if you have lots of dietitians and lots of time, I think that is definitely possible. But I think looking at resource implication is something to think about. So then it's what to use and how to use it. So if you've got persistently increased PTH above the specific target range that you're aiming for, you should try and use it. But if they've got a lower calcium, correct that before you start using it. But also make sure that you have corrected the high PTH firstly with vitamin D supplementation. They then talk about what is the normal PTH target level that you're aiming for. This paper suggests that we should aim for a normal PTH and CKD ages 2 to 5, and those during dialysis 2 to 3 above the upper limit. Other papers look at 9-fold above the upper limit. So then dosage, start at the lowest dose. You can have any of the analogues that you want to give, so 1 hour for calcitriol, Temepla, and route ideally daily, or you're more likely to remember it if you have it every day than every other day, I think. So if you can do it daily, or that's probably the best way of looking at it. So then KDIGO 2017 is quite a big document, but great summary at the beginning, and you can delve into detail for paediatrics as you need. It gives a good idea of frequency. So obviously the CKD 5 more often, and then 3 less often. And then checking ALP every 12 months in the presence of elevated PTH. But like I said before, it happens with every blood test because we do liver function tests anyway. So that gives you an idea of frequency, the recommendations for frequency. And they also suggest that it's reasonable to increase that frequency to monitor the trends and anything that you're doing with treatment and the efficacy of the treatment. Doesn't suggest frequency measuring vitamin D, suggests the recommendations for general population, but then the previous papers by Schott gave a really good idea of frequency. Looking at trends is kind of what they focus on, and rather than a single value, taking into account all available CKD and MVD measurements, so vitamin D, calcium phosphate. Looking at calcium phosphate as individual values other than product, looking at serial measurements, and they should all be considered together as part of that CKD and MVD kind of package. Aiming to phosphate and calcium is in the normal range, looking at phosphate restriction, and the choice of phosphate binder based on serum calcium levels. Now, regarding phosphate binders, we looked at nice guidelines on hyperphosphatemia, which were published in 2013. And the first 9 binders calcium based. But if the calcium is towards the upper limit of normal, then using a combination with Svellar, but also look at other causes of rising calcium level, i.e. other than a supplement. Sometimes it does get forgotten unbelievably. So PTH, again, the optimum level is not known. Looking at vitamin D supplementation, and if you need to use calcimetics to lower calcium, they suggest that also. That kind of summarises a few things that previous papers have said already. So this is the guideline that we came up with after pulling things together. And you'll see that we changed the vitamin D box to kind of suit our practice and made us feel a bit more confident in what we were going to do. And also we matched it with the liquid and tablet preparation that we had in the trust. Later in the year that will change again, and then we're going to adapt the table again. So you'll see that we've put down the frequency at the top, what we would like PTH to be and what range, the calcium and the phosphate are there, and acting on the modifiable factors together, so drawing in everything together. What we haven't got on here is dialysis modality and dialysate composition, which I think we do automatically, but maybe that's something that we should look at adding to this. So just summarising that then, management of CKD and MVD should be based on serial assessments of phosphate, calcium, PTH and vitamin D. Therefore, dietary management is a combination of dietary assessment, manipulation of calcium and phosphate intake, and the treatment of vitamin D deficiency. So hyperphosphatemia and hypocalcemia contribute to the pathogenesis of secondary hyperparathyroidism. It's a long word. And then optimal control of bone and mineral homeostasis is essential for preventing skeletal complications, achieving adequate growth, and preserving long-term cardiovascular health. So it's all bearing that in mind. And what I will say also is when you're looking at phosphate and calcium, knowing your renal replacement therapies is crucial to know your clearances of phosphate and using binders. So managing modifiable factors, looking at calcium first. So with calcium and phosphate, there's a balance between protein. And so in calcium, it's protein and phosphate, and if it's phosphate, it's calcium and protein. There's that kind of balancing all those together, which can be quite difficult. You may need a supplement of calcium, which you could combine with a supplement of vitamin D. Sometimes you find if they're on a potassium restriction, they tend to not always take a lot of calcium or enough calcium in the diet. Remember your binder content as well. Depending on the literature that you read, the absorption of elemental calcium can vary from 20 to 40%. So also bear that in mind. And there's less so, obviously, calcium in the calcium acetate. Make sure that the binders are used correctly, depending on which one that you're using. So if it's a calcium carbonate-based one, ideally before the meal, and the right amount as well. And just checking on that compliance as well. Requirements of calcium vary with age. I use the Department of Health guidelines. I tend to use a quick checklist as a quick assessment in clinic, and further details if I need to later on. And if there are dialysis, you could look at dialysis fluid. Here is just my checklist that I use. Very crude, but it's sometimes if they are having dairy products, it's a quick way of seeing if they're having enough calcium in their diet. And you can also adapt that for yourselves. And again, we produce this actually for nephrotic syndrome to make sure they're having enough calcium in their diet. But on the back of this, it's got the non-dairy produce. Yes, the bioavailability is different, but you can count some calcium from non-dairy, and gives other options for families if they don't like dairy foods. And then phosphate then. We previously mentioned when should we restrict phosphate, and the idea is could be as early as CKD 2 to 3. And why is that? FGF23 is working earlier than we see the PTH rise. So should we not wait for the PTH to rise now, and actually at CKD stage 2 look at phosphate restriction then? When we say phosphate restriction, actually it's phosphate to requirement, which is healthy eating really. I think we all have too much protein in our diets, and if we reduce protein in our diets, automatically reduce phosphate. Now, when I say reducing protein, I don't mean below requirement. You still need to have enough protein to grow. That's must happen. So in essence, it's healthy eating. If it's just looking at phosphate in foods without looking at phosphate additives, which I'll come along to. It does suggest, though, if we did do this, we could delay disease progression and decrease mortality risk from cardiovascular disease. So there is very much benefits out there for going in earlier. That's just a nice diagram kind of summarising FGF23, how its primary goal is to increase excretion of phosphate. So you have a bit of a compensatory factor, so you don't see a high serum phosphate. You will see PTH starting to rise as FGF23 goes up. So it's just a nice schematic there for you. So managing modifiable factors, so looking at requirements. So in the UK, we do it by weight. So that there's the references there. And then the clinical practice recommendation that came out this year, they suggest suggested dietary intake. And there's we've got a nice little summary there of that. And I think from the clinical practice recommendation, it's going to be a practical guide that will help with that as well. It's difficult to do phosphate restriction, the same reasons as I mentioned before, protein and calcium intake. Some dietitians look at protein to phosphate ratio. I don't look at that. I just look at individual dietary preferences together with calcium, together with protein. I think that's enough for me to be doing, but I'm not saying that's wrong, but it's another way you can look at it. You will be aware that the bioavailability within different groups of foods varies 30 to 80%, so lowering those that are lower in plant than meat and dairy sources. So lower in seeds and legumes, and that's due to the limited GI absorption of the phytate that's bound to phosphorus. There is, of course, the issue of inorganic phosphate in the form of preservatives and additives, and the bioavailability could be up to 90%, and this could add significant burden to the diet. It really kind of needs to be factored in. But you can see that a child could easily meet their phosphate requirement by lunchtime if they have a bit of milk, a bit of cheese and yogurt. So it's kind of education around that. And I tend to use swap lists with my patients. Coming to phosphate additives then, so in the UK and Europe we have E numbers, and I think in abroad it's a prefix of phos, it's a phosphate additive. Now previously, and I still do suggest that if children want to fill up on foods, cakes and biscuits were a great high calorie food, low protein and low phosphate, but you can see that it's used a lot in processing of these foods, and so can add up to 50% phosphate to the diet. Food labelling is difficult because companies are not by law required to show the phosphate additives on the labelling. As a department, we did a little bit of work on this. It did take a lot of work and it take a lot of maintaining this, but we kind of looked at phosphate additives on snacks, contacted some of the companies to clarify whether they were correct, and other companies where some foods, some variety of biscuit had the phosphate additives on and the other ones didn't. We've assumed that if they put it on one but not the other, that this product doesn't contain phosphate additives. Of course, reminding yourself that if the product has got nuts in, that's a phosphate source too. But it's worth kind of exploring that with patients with labels. To summarise phosphate then, watch protein and calcium, education on food labels. As much as you can, choose fresh produce. And again, cooking and confidence with cooking, if that would help. To avoid high phosphate foods that have low nutritional value, I'm thinking of fizzy drinks really for that. Know your binders and how best to take them. And yeah, consider using swaps that individualise their preferences as well. So vitamin D. I think increasing the awareness of the need to check levels is important, and we've certainly done that over time with our team. Check with the lab what assay you're using. Also be aware of local preparations and those used in primary care. You may need to modify your recommendations for ease. We certainly have, and you will need a supplement. I really don't think you're going to get enough in the diet, so I think I've had referrals previously saying, can you increase it in the diet? You know that vitamin D is 20 or something. It's, you know, you're just going to have to bite the bullet and use the supplement. Just a few slides on resources. So as I mentioned before, the guidelines from the task force, and there's a practical guide on its way, which I've read the draft and it's excellent. Any publications, you saw the ones I looked at there. There's more since then, but at that time I used those. Websites, so in the UK we have InfloKid and VIA. Any network groups that you have, so in my case I have Bring and a raft of knowledge with my colleagues, and we email each other, you know, can you help me with this, and have you done any resources on that, and we share resources. Any games that kids like to play, it always engages the younger kids, doesn't it, and it stays in memory more. There's some cards, higher and lower cards that Vitaflow are developing, which I think I have on the next slide. Any recipe books, so there's one that came from Bristol that's got like a traffic light guide on recipes. You can see that on the picture there. Any apps, so Great Industry developed an app with Shelley regarding potassium phosphate, sodium and fluid. There's a game on there, and there's text to read, and there's also a video about phosphate, so that also helps too. Any diet sheets that you may have, any swaps relevant to your population or to that patient. So I've got a massive grid of phosphate containing foods, and I'll adapt it to them, or I'll do like a treat list or swap list for them. Cooking demonstrations not to be underestimated. I think a lot of our mums and dads aren't confident with cooking or modifying meals. I know a couple of my colleagues up and down the country have done cooking demonstrations and they've had positive feedback from that. So I think doing those things is always useful to do. The education card, so you can have a bit of a game with the children about what's high and what's low, or what, compare different drinks, different foods to cottage cheese versus hard cheese, or rice versus mince, that kind of thing. It could be good fun actually. There's recipes and there's other drinks out there. So you have low phosphate containing supplements, which are the juice-based ones. You have milk substitutes, so Pro Zero being one that, and Snow Pro, Renamil, other low potassium formulas, Renestep, Kinogen are out there. So Vitaflo have done some lovely recipe cards to adapt those drinks to. So you can have milkshakes, and sometimes I mix Pro Zero with cow's milk, so you're getting 200 mils, so 100 mils of each, but it's lower in phosphate, but they're still getting a bigger drink. And sometimes you can grade that over so they get used to the taste of the milk substitute. And adding stuff to it makes it exciting, and making milkshakes together is always fun, especially with younger children. There's some recipe downloads out there. So the next 3 slides are with thanks to Chris Nelms from the States. She's on a talk that we were working in the beginning of the year at, and they were great to have a look at. So it just gives you an idea of how much is out there and what you can access. So any apps that might be out there, and then how to find apps. There's a great page there for you to be aware of. So I'm up to next. I think I'm going to take my advice and look at vitamin D status and PTH. So what I'm hoping to do is pull data together from 2013 to now at different data points, and see what our PTH and vitamin D status are across our CKD population, and see if we've improved, and of those that we're doing well with, what have we done that's gone well, and those we're not doing well with, what's happened to those children, and see how we can improve things. I hope you found that useful, and I welcome any questions.
Thanks, Layla, for taking us through this topic in so much detail. There are a few questions that have been submitted. I have one here, Layla, that has come through. When you completed your very first guideline or audit back in 2013, did you notice any improvement or changes in the patients you were working with, or maybe in the team's practice around that time?
I did initially. I think, isn't it always the case when you start off something, you start off with great energy, and so I think we really focused on things, but I think we did see some changes, and we did increase the awareness of vitamin D, but I think we hadn't probably appreciated the different preparations that we had, and getting the right preparation and getting confident in supplementing it, because at the time we were just using the British National Formulary, whereas now with the Schroff paper you've got a really nice table that gives you an idea how much you should be supplementing, so that might help us now. So yeah, we did see some changes, we did definitely highlight it. We have come on from what we had done, definitely.
Great, so that's good to hear. Another one that we have here is just in relation to the phosphate intake. So in your practice at the moment, would you now start to limit phosphate intake earlier? So maybe in CKD stage 2, or?
To be honest, no, not really. I think the resource implication for us would be huge. I think we are thinking about, I discussed it with some colleagues, whether we produce some healthy eating guidance for CKD stage 2. I think with reducing protein intake in your diet, because we all eat too much protein, that will ultimately phosphate. The mudding of the waters is, of course, the phosphate additives, and then do we then do education on that? And would people feel comfortable reducing the phosphate and protein content in CKD stage 2? The evidence does seem to be out there, and I think we would have to either produce a leaflet to give some advice or see them just once, but for us the resources for that would be huge. So maybe I think what we're going to focus on now is getting our 3, 4, 5 population, tested at the right times, given the right supplementation, getting that tidied up as much as we can. I suppose though you shoot yourself in the foot a little bit, because maybe had you caught it at CKD stage 2, you might have less at 3 and 4, 5. I think we just need to first of all get tidy at what we're doing now, and then do look at our approach at our CKD stage 2.
Okay, sorry, you dropped out a tiny little bit at the end, but I think you were saying that it's just a bit of a challenge from the resource point of view and figuring out how you would do that at the moment. Thank you. There's a couple more questions here. One of them just asked if there is any difference in vitamin D level in the summer compared to other seasons, and would vitamin D kind of prescription change at all based on seasonal difference?
I mean, that's certainly what some of my consultants discuss with me and saying, oh, in the summer they'll be fine. I haven't seen the variation, but to be honest with you, I haven't checked it religiously. And the guidance to being 75 from Schroff papers is looking at seasonal variation and accounting for that as well. Like I said, I have seen it drop quite quickly, and I can't say it was in winter or in summer. I think it's not just the going outside that's the issue. It's being the synthesis in the skin and the production of the hormone in the kidney. And I don't think it's just so much going outside and getting vitamin D from the sun. I think you've got so many other factors. I don't think we've ever seen an overshoot because they went out in the summer either. But again, that might be something to look at. Yeah, that's a good question. But I haven't seen it. I've seen more of a drop from when we've just stopped the vitamin D supplement.
Great, thank you. And there's 2 more questions here. The first one is, could you specify when you're checking vitamin D levels, is that only 25 OH vitamin D, or would it be worth checking calcitriol or active vitamin D as well?
Yeah, so when I looked at the paper, it only suggested doing the 25 to check that. I think some of my team have said, should we look at the active? And we haven't, and we could do a comparison, I suppose. But I think if we've got I feel we've got a nice guideline that suggests the 25 and suggests a level. And I think if that's our starting point, and then when we look at, our PTHs and vitamin Ds later on, and if we go back, oh, actually, it hasn't worked, should we look at something else? That might be something that we come up with. I'd be more interested in looking at urinary calcium, to be honest with you, when we have urine output. Yeah, that's a good question.
Great. And finally, do you have any more advice on how to promote the role of the dietitian within an MDT, where maybe dietitians are not already embedded within the MDT, or where any starter point?
Well, that's a tough question. Any starter points? I think the difficulty is, isn't it, that you want to highlight what you're doing. In order to do that, you need to show what you've done. And if you haven't got the resources or the time, that's difficult, isn't it? I think if you can do small audits or quality improvement projects to show that what could be offered, or if you have time to look at the literature out there, because in renal now there's more and more out there showing the need for assessment by a dietitian, and the need for frequent contacts with dietitians increases growth and quality of life. I know that Christina Nelms and Brad through the task force have been working on an assessment practice guideline, which will be useful maybe, and it pulls together kind of how often dietitians were reviewing and the outcomes. So it might be that you have to fall on literature if you haven't got time to actually see patients yourself. I think if you have any meetings or you have any presentations that you can attend, so if you can get to a half an hour business meeting or do a presentation, although nerve-wracking as it can be, The more and more you do it, it does get easier. That can also be useful to highlight the role of the dietitian. I hope that helps. I'm trying to think what else to say, but I think
Great.
that's what I'll do.
Great, thank you, Layla. We're just coming up to the hour now, so I would like to thank you, Layla, for presenting today, and apologise again for that sound quality. We hope the rest of the presentation has been informative and helped advance your knowledge in this area. So this concludes today's webinar, and on behalf of VitaFlow, I would like to thank you all for tuning in today, and thank you, Layla. Please take the time to complete the evaluation questions before you leave the session. So goodbye from myself and enjoy the rest of your day.